like this. And I introduce the endoscope. This is the upper side of the cyst. We cannot see the microscopic view, but the endoscopic view, we are easily to find the residual cyst contents. This time I don't use endoscope holder, so I hold the endoscope left hand and right hand I hold the suction. Epidermal cyst is, it's not bleeding so easily to peel away from the wall, but this portion is very hardly to remove, very tightly adhered. It's okay. Here is open the previous surgery. So we cannot alter the cyst wall of the tumor, but the maximal reduction of the cyst contents. This is preoperative MRI and this is postoperative MRI. I think epidermal cyst, when we do the epidermal cyst microsurgery, we cannot see that this portion is blind, so we cannot remove. But endoscopic view is very wide view, so we easily to remove this portion. Next case is 45 years old female. She had right trigeminal neuralgia, and this is preoperative MRI. She had right serpentine angle or epidermal cyst like this. This case also firstly microscopic resection. And we can see here that this is cerebellate cranial nerves and this is petrous vein. And this is fifth nerve hardly attached here, the cyst wall. This is the first case of the epidermal cyst, so we have to remove the cyst wall to avoid the recurrence. We detach from the pons and we confirm the sixth nerve like this. And microscopically, gross total removal was achieved, but next we introduced the endoscope, so we easily found the residual cyst contents here. It's below the fifth nerve. It's easily removed like this. And after that, I conferred the internal auditory canal, and this is a fifth nerve pushed up by the cyst. And here is Greibach and sixth nerve and pons, and here is ICA. There is no residual contents. This is preoperative MRI and postoperative MRI. Its gross total removal was achieved. And next case is vestibular schwannoma, and this patient is 77 years old male, and he had left facial palsy and gait disturbance. This is preoperative MRI. It's cystic vestibular schwannoma, and the cyst compressed left pons. So this time we use 2D beaton and endoscope. Firstly, we resect by 2D beaton. Firstly, we open the cyst wall and debarking, and after that, we detach around the vessels and here is a fifth nerve, and we check the service nerve function by the NIM response. Sorry. We cannot find seventh nerve anatomically, but we can check the seventh nerve running around here by the NIM response. So we cannot remove the tumor capsule. And after that, we use endoscope. This portion is we cannot see 2D beaton, or sometimes we do the microscopic resection. We cannot find or check the residual tumor here, but easily we can see here. And this time we didn't open the internal auditory canal here, but this is 30-degree endoscope, and this is 70-degree endoscope. This is final view of the surgery. This is preoperative MRI, and this is postoperative MRI. This patient is very highly aged patient, so a little bit tumor is here, but it's not so problem. The next case is a 48 years old female vestibular schwannoma patient. He had a left hearing loss and gait disturbance. This is a preoperative MRI. A very big tumor compressed the brainstem, and left internal auditory canal is widely. And this time also we perform the left retrosigmoid approach, and firstly we check the raise the seventh nerve running by the NIM response, and we cut the tumor. And this is lower cranial nerves. And first, developing the tumor and very easily bleeding. We resect the piece by piece fashion, and we use ultrasonic aspirators also. And gradually detached around cranial nerves and vessels. And this time also we cannot find the seventh nerve anatomically. So we open the internal auditory canal. And here we can see seventh nerve here. And the seventh nerve running the upper side of the tumor, and we detach the deep portion of the tumor. Sorry. And we can see here a basilar artery. I think seventh nerve running around here. The microscopically removal is like this, but medial side of the tumor is here, but we can't find the dissection plane. So next we introduce endoscope here. This is petrosal vein. And this is petrous bone. And we elevate this. This is tumor, and here is brainstem. This time we use endoscope holder and bimanual resection technique under the endoscope. We remove the piece by piece fashion of the tumor. And after elevated tumor, we can see from the microscopic view the residual tumor, so we remove again by the microscope. But this tumor very tightly adhered the brainstem, so a little bit residual tumor here, but the patient recovery is very good. And next case is meningioma. The patient is 60 years old female, right petroclival meningioma. And she had right trigeminal neuralgia. The tumor is embedded into the internal auditory canal. So this time we perform the right anterior transpetrosal approach, This video already done the anterior petrosectomy. And firstly, we cut the posterior fossa dura and confirm the posterior fossa tumor. And after that, we cut the temporal dura and retract the temporal lobe and cut the tentorium. We can see here is a tumor, and we confirm the fourth nerve here at the pons. After that, we perform the mass reduction of the tumor. And here is the right trigeminal nerve. And resect the posterior part of the tumor. After that, we open the internal auditory canal here, running like this. After that, we introduce endoscope. This is 30-degree endoscope, and we check the anterior part of the tumor. His trigeminal nerve and clivus here, and fourth nerve is here, and pons. Under the endoscopic surgery, the same procedure, we can do the microscope. It's basilar artery, and we detach tiny vessels around the brainstem. Like this. And this is preoperative MRI. This is postoperative MRI. We can remove the clival tumor, but a little piece of the under the internal auditory canal tumor. Next case is meningioma. This patient is 64 years old female, left petroclival meningioma or posterior crinoidal meningioma. She had double vision, and this tumor shaped multilobulated. This case, we perform the left anterior transpetrosal approach and transcerebral approach. Firstly, we perform the transcerebral approach, and we check the tumor around the ICA. Unfortunately, the tumor is soft and suckable, so easy to remove. Next, we perform the left anterior transpetrosal approach. We cut the tentorium, and we found the trigeminal nerve, and we remove the posterior fossa tumors. Here is infratrigeminal part of the tumor. And after that, we introduced endoscope. This is super left trigeminal nerve part. It looks not clear, but there is no residual tumor. And we next check the cadaver portion, and this is infra-trigeminal nerve area. After that, this is and next to our back to the left trans Syrian approach, and we can see his ICA and his anterior choroidal artery. She had two anterior choroidal arteries. And this time I use clearable endoscope. This is 30-degree endoscope, and we cannot use endoscope holder, so this is one-hand surgery. This is preoperative MRI, and this is post-operative MRI. A good resection was achieved. And in the endoscopic assisted anterior transpetrosal approach, the authors described that anatomic exposure is endoscopic Kawase is 3 times wider than microscopic Kawase approach, like the images, but surgical freedom is also almost same. It means we can see more wider area of the around the brainstem, but we cannot touch the object or tumors. So, for obtaining wider surgical freedom, we use malleable instruments like a suction stick, bipolar, and dissector. This is a malleable dissector. And this is a malleable tip bipolar. Like this. When you use angled endoscopic surgery, this malleable instrument is very useful. And also we usually use fluoroscopic type pneumatic endoscope holder like this. Conclusion is as below. Thank you very much.
Есть вопросы? Если нет вопросов, следующая лекция будет. Есть?
Thank you very much. It was a very good talk, and especially coming from Nagoya. I've been to Nagoya many times, and you've been very well taught by Professor Yoko Kato. I think my comment would be that I think those who would like to undertake endoscopic surgery, posterior fossa endoscopic surgery is very difficult because it is very shallow and you do not have the length there. So I think microscopic assisted endoscopic surgery would be a very good idea, and especially for CP endal tumors like the epidermoid that you have seen. But I think for the acoustic neuronoma, I think I would go for a very small acoustic neuroma, less than 2 centimeters. Other than that, large endoscopic, large acoustic neuronomas probably would be difficult to be removed by endoscopic surgery. But I think at the end, you can link into the internal acoustic foramina and also the brainstem and cranial fossa, cranial nerve areas where you want to see. Thank you.
Thank you.
Спасибо.
Спасибо.
Следующая лекция по эндоскопической хирургии мозжечковых гематом прочитает доктор Шигео Ямаширо.
Okay. My name is Shigeo Yamashiro, and I appreciate Professor Dr. Supiano and other colleagues for coming this seminar. My repertoire of the endoscopic surgeries is a little bit different from other endoscopic surgeons. I am talking about endoscopic evacuation of the hematoma. And this is my hospital. I worked at the Saiseikai Kumamoto Hospital, which is located in the here. South part of Japan, Kumamoto Prefecture. There is a major 12 acute service center. My hospital is one of these ones. And this is an air photo of my hospital. And this is the main hospital building, and they have cancer center and preventive medicine in other buildings. The neurosurgery department is occupied the third floor of this building. This is the number of surgery in Saiseikai Kumamoto Hospital, 2009 to last year. Last year, we have 678 cases of neurosurgical cases. Microsurgical clipping, 144 cases. And other, we have microvascular decompression or carotid endarterectomy here. Today, the endovascular surgery is included in the other surgeries. And this is my experience cases from the 2007 to this year. We worked at the two centers, Kumamoto Rosai and Saiseikai Kumamoto Hospital now. So I started the hematoma evacuation from 2009. So the cases gradually increased. Last year, we had 26 cases of hematoma evacuation. Today, I focused to the cerebral hematoma. The main location of the hematoma, the terminal hematoma occupies 43% of all cases. Today, cerebral hematomas. So, you know, the cerebral hematomas, the most golden standard method is suboccipital craniectomy. This is the illustrative cases, the right cerebral hematomas. So the patient is in prone position and the midline skin incision and craniectomy. So cortical incision here and evacuation of the hematoma under microscopy. So third cells here for hemostat. The hematoma is been totally removed. Now, this is a standard. So on the other hand, endoscopic surgery is so-called bar-hole stoma surgery. This is a diagram of the intraoperative hematoma evacuation. This is transparent cyst is here through the bar hole, and this is the endoscope and suction to the hematoma, and under the endoscope, the hematoma was sucked. And this is a real photos. Rigid endoscope in the inner and outer cyst, that to the hematomas. And when I suck the hematomas, only use the outer cyst, the endoscope and suction into here. This is the illustrative cases. And 80-year-old female had left cerebral hematoma. The volume is 50 milliliter. Some doctors choose conservative therapy. This is not so large hematomas, but 12 hours after arriving, the patient's consciousness going down because of the obstructive hydrocephalus. So we decided to operate this patient, not only ventricular drainage, but also endoscopic evacuation. And this is the position is lateral, and the anesthesia is local, and intravenous infusion of anesthetic agent, for example, the diazepam and dexamethasone. This case, the frame is fixed in the patient's head because this one helps an accurate puncture to the hematoma. But not always use this one. And the skin incision is marked here. Intraoperative endoscopic view. The transparent cyst is into the hematoma here, and in many cases, the transparent cyst into the hematoma, the large clot was evacuated, and 20 to 30 minutes, hematomas all evacuated. You can see this one may be the floor of the fourth ventricle. The third cell into here for hemostasis. The hematoma is totally removed, and the ventricular drainage is inserted here. The patient had a good post-operative course and transferred to the rehabilitation facilities. Another case, 61 female, left cerebral hematoma. It's so large. So the patient transfers from the ER to the operation room, and under local anesthesia, the operation started. Excuse me. Then the same method like that. In this case, the hematoma is very soft, easy to suck. At the first stage, hematoma come here, and after 10 minutes, the hematoma is already removed. The hematoma is almost removed here. The last case, 88 years old male, and this is the oldest case in my series, right cerebral hemorrhage. This is the last stage of the operative view. This is the flow of fourth ventricle here, that's clearly visible. And we can see the CSF flow down from the aqueduct. I confirm this CSF flow, so the ventricular drainage is not always necessary, I think. The hematoma is removed. And this is a summary of my experience cases, 29 cases. Mean age 72 years. The mean hematoma volume is 30 milliliters. The mean hematoma evacuation rate is 85.5%. The outcome here, 61% of all cases shows modified ranking grade 4. And we experienced death cases in 3 patients. Two patients had rebleeding, and 1 had pulmonary embolism. So as for surgical evacuation of cerebral hematoma, in about craniotomy, just had general anesthesia and prone position. It needs a suboccipital, sometimes large craniectomy, and ventricular drainage into the posterior horn if needed. While endoscopic surgery, we selected local anesthesia. Sometimes general anesthesia I choose if needed. And lateral position, suboccipital bar hole, and I think ventricular drainage is not always necessary if the CSF flow of the fourth ventricle are visible. And this is a summary of my cases, and I compared the craniotomy group between endoscopic surgery. You can see in the endoscopic surgery, I operated more aged patients because of I think the less invasive method. The evacuation rate is not good than the craniotomy, but the operation time is very short, 1/2 of the craniotomy, the operation time. Some reports had, some also had advantage of the endoscopic surgery. So every author reported a very good evacuation ratio. And Dr. Yamamoto, he is Japanese, reported so short operation time, 74 minutes, very less invasive surgery. Technical pitfall in this method, intraoperative patient movement because of the local anesthesia. I always use the dexmedetomidine. It's a very good anesthetic agent. This one effectively calms the patient. And second, mislocating the bar hole because of thick cervical muscle. I think the best location of the bar hole is between the mastoid process and the midline. In the middle of the mastoid and the midline. So but the beginners of this endoscopic surgery sometimes make the bar hole the other point. So I recommend for beginners, I recommend the general anesthesia for the patient, and because of the patient did not move. And sometimes usefulness of navigation system, I use this one. So the conclusion, the neuroendoscope is effectively and safely applicable for the cerebral hematomas according to its minimal invasive properties. Thank you very much.
Спасибо, доктор Ямашира, за интересную презентацию. У кого-нибудь есть вопросы?
Thank you, sir, for your talk. I have two questions. The first one: what is the median level of consciousness for your series of cases? And the second one: you mentioned that in your series there were 10% mortality, only 10%, and 29 patients, 3 died. And what is the follow-up to assess the mortality cases? Thank you.
Excuse me. And your first question is, what is that?
What is the median level of the consciousness of patients, or the level of consciousness?
How to use the...
where all of them were awake or not? Like, do you use?
Yes.
What is the level of Glasgow Coma scale?
It was a very good point. The patient is, and it's very important to not to move the patient. I use that I present the dexmedetomidine and patient consciousness down to the GCS Glasgow Coma scale 10 about. Do you understand?
Yeah, I understood. My question was not about not about this point. What was the condition? What was the median condition of the patients when you decide to operate them?
Preoperative indication. And I decided to operate the cerebral hematoma, and the patient condition is maybe the Glasgow Coma scale. So 10 or under.
10 or under, you decided to under.
Yes.
Okay, and why?
Second.
No, that's my next question was, why did you didn't choose to operate them for the GCS scale above the 10? Because it is very predictable. The Glasgow Coma scale would worsen if you don't operate them.
I operate the excuse me, the
okay, if they are totally awake and they have intracerebral hematoma, you decide not to operate them. Am I right?
yes.
But it's very predictable that the level of that their condition would worsen in a definite period of time. Why would you didn't operate them when were you awake?
Because that in that case the hematoma volume is 15 milliliter. It's not so large. So I choose conservative therapy at first, but the patient consciousness is down, so I decided to the operation.
If I may add something to it, a comment by the gentleman who was asking about, there are set international protocols that why would you be operating on intracerebral hematomas. And I think as our colleague is saying, if it is between 9 and 13, if it is more than 13, you do not operate. If it is less than 13, you do not operate. The other question is, why to operate if they are conscious? It is not only the GCS or a Glasgow Coma scale, it is the volume and the midline shift. According to that, you decide. And the third thing is that if you have a hematoma between 9 and 13, if you keep the hematoma there, they can expand. And they are expanding hematoma, and that is the reason patient should be removed the hematoma. These are international protocol for removing the ICH. Less than 9, the results and the outcome are very poor. More than 13, do not operate their all conscious patients.
Yeah, I totally agree, but it is the protocol for supratentorial hematomas, not for subtentorial. It's totally not the volume, the level of consciousness. But okay, and what it's 10% mortality. It's very low.
So
Very low. It's very low. What is your follow up to assess the mortality?
After the operation, I follow the operation very strictly for 2 days, but not anesthetic. So patient followed awake. Not a special method to follow, I think.
Okay, what was the duration to assess the mortality of the patients? Is it only hospital stay 1 week, 30 days?
Yes, 1 week.
1 week. Okay, thank you.
Можно я на русском? Я не понял до конца. Вот показанием к операции у вас служит объем гематомы или состояние сознания больного?
Main indication. So the hematoma volume is over 20 milliliter, or the diameter is 3 centimeter over, and the patient consciousness going down. It's an indication for operation. Either, yeah. But patient if the patient awake, but the hematoma volume is over 30 milliliter, it's an operative indication. Because maybe the hydrocephalus is maybe coming to the future.
Еще вопросы?
Вопрос по первому вашему кейсу. Если мы можем вернуться. Такой вопрос. Вы гидроцефалию связали именно с гематомой? Ну, с тем объемом, который вы показали? И какая клиника была представлена? То есть сознание в каком состоянии было?
You mean the why the hydrocephalus coming to the cerebral hematoma? Is that so? The association of the hydrocephalus and the cerebral hematoma.
Да, вы связали гидроцефалию связали с гематомой. Ну, почему вы решили оперировать эту гематому в первом случае?
First case, yes. Maybe that case, the hematoma is not so large, but hemorrhage come to the fourth ventricle and aqueduct up to the aqueduct, so it's the cause of the obstructed hydrocephalus. Okay.
Все, понял.
May I again elaborate on the point that the gentleman has just asked? I don't know, because the question was directly to him. I could not hear that. But I think the philosophy of removing the intracerebral hematomas, other than the conscious level of Glasgow Coma Scale, the volume, and the midline shift, is that the hematomas, they create ischemic changes. And if you do not remove between these two areas, or more than 20 ml, they will create ischemic changes there, and either they will have a motor, or they could have a speech, and or they can have even the epileptogenic source for that. And that is the reason, other than the hydrocephalus and creating CSF flow obstructions, that is the reason why we remove hematomas if they come into that protocol. There are many reasons for that. And I think it is quite a debatable issue, but I think everybody agrees that if there is no comorbid factors, if the patient is young, hypertensive, it is a different ball and game. And if the patient is elderly patient, you can do it under local. And if the patient's GC scale is low, then I think it is debatable whether you should be removing or not, because the outcome is not very good.
Thank you very much for helping me.
Спасибо, доктор Ямашира. Следующую лекцию прочитает доктор Шигеки Оно на тему гибкая нейроэндоскопическая малоинвазивная хирургия при нейрохирургических заболеваниях.
Thank you for giving me this honorable opportunity to show my data, and also thank you for kind of your hospitality. Today's my talk is flexible neuroendoscope. Maybe in Europe countries, people don't use this kind of flexible neuroendoscope because of sterilizing problem, for example, CJD. So this is a Japanese flexible scope talk. I'm not sure who he is. This morning, I'm walking Riverside Bank. I found this ancient man. You know, maybe. Okay. So I'm come from Okayama City. This and Vladivostok. This is Russian territory. Vladivostok here, Tokyo, Nagoya, Osaka. Okayama is here. It's the same origin from Professor Kurozumi. He presented before. The Okayama is here, just beside to Hiroshima. You know Hiroshima? Maybe you know. So this is Okayama Castle, ancient castle, and cherry blossom here. In the end of March, there are many cherry blossom around Japan. So please visit Okayama. So this is my hospital, Kawasaki Medical School General Medical Center, located in the center of the Okayama city. I am a director of neuro surgery and chief of stroke center. So let's talk about the flexible scope. This is an ordinary conventional fiber scope. So there are many fibers gathered with one flexible shaft. And this is a video scope. So maybe you also see this kind of video scope in GI manipulation, flexible one. This is a video scope was provided for special neurosurgical technique operation. So provided by Olympus. This is a ordinary fiber scope, and this is a video scope. Outlooking is not so different between them. And tip. This is a channel, and caliber is a little bit bigger than conventional one. 2 light source there, and one CCD camera on the tip of the shaft. So short video, I will show you. The manipulation is almost the same for GI flexible scope. Shaft is a little bit shorter than that. So we can rotate the tip with this channel. So zoom can be used. And this is one channel. And we usually use this artificial CSF for especially ventricular manipulation. So what about indication of neuroendoscopic surgery for especially flexible scope? Hydrocephalus, yes. Third ventriculostomy, plasty of foramen Monroe, lamina terminalis fenestration, suprapineal recessus tumor biopsy, and septostomy also. Foraminoplasty, choroid plexus coagulation, shunt catheter placement or removal will be used in this video scope. So for intraventricular tumor biopsy was usually used this flexible scope, but total removal is very difficult. The endoscope view is very narrow, and stopping breath is difficult. So partial removal or biopsy, we use this endoscope. And cystic region is good indication, fenestration, aspiration, removal. and intraventricular hemorrhage or ventriculitis, we use this endoscope. So these are my case, experience case. The teratoma with hydrocephalus, the ventricular, this was choriocarcinoma, and choroid plexus papilloma. This is very big, so usually we use craniotomy after the biopsy by videoscope. This is a lateral ventricular lymphoma. Central neurocytoma is a very good tumor for removal by neuroendoscope. And this is a trigon meningioma. We use this endoscope for these tumors. So procedure, ETB biopsy is frequently adapted this videoscope. Superimposition, no rotation, one bar hole surgery. And usually we use general anesthesia. And stats of this videoscope is the following. Tip diameter 5 millimeter, a little bit bigger than conventional one, and length is shorter, and the channel caliber 2 millimeter. Angle of tip is 90 degree, and the view angle is wide, very wide, 120 degree. And depth of focus is automatically focused from 1.5 millimeter to 50 millimeter. So this is a representative case of ETB, and this is a preoperative CT scan. This is a postoperative. I will show you short video. The drainage was inserted, so make a hole of drainage. So a view is, I think, not so bad. It's clear, so I fenestrate, not to use coagulator or electrode, because it's very dangerous to breathe for use electrode. So this is a view of ETB by videoscope. So these two cases are typical aqueductal stenosis case. Upper 3 panel is case 1. Lower 3 panel is case 2. This case, aqueduct, the entry of the aqueduct is very enlarged, and very thin wall, small membrane, was in the middle of the aqueduct. In this case, it's very narrow aqueduct, you can see, like this. And you can see this endoscope, whole lateral ventricle, and the third ventricle, anterior side and posterior side, in the same one endoscope. So what about quality of fiber scope and the video scope? This is a conventional fiber scope. Pictures quality is not so good, I think. So video scope, third ventriculostomy can be easily done because of good view. So we can define the small vaginotope artery like this. So this is a tumor biopsy case, third ventricle lymphoma, same patient. This is a fiber view. This is a videoscope view. So I think it's a little bit wider than conventional one. Biopsy is easy because the vascular structure can be easily seen compared to the ordinary fibroscope. So breathing point is easily find out. So, and then I performed a septostomy, same patient. So septostomy, we need some angle to the septum in the same bar hole, from the same bar hole. So septal vein is here, lower septal, upper septal. Between them, we can penetrate the septum easily using this endoscope. So next is a comparison between rigid endoscope and videoscope. So this is the foramen cavernous hemangioma case, same patient. So rigid Stolz endoscope is very clear, and also natural color, I think. So, but videoscope view is not so bad, I think. So we get more wider view than rigid Stolz scope. Quality is not so bad, I think. So this is also representative case, teratoma biopsy, 5-year-old teratoma case with hydrocephalus. Videoscope was inserted into the posterior portion of the third ventricle. You can see, already see a huge tumor. So here is a massa intermedia. Tumor capsule firstly removed. This tumor is actually very firm and elastic, very hard tumor, but we can make a biopsy so from the wide view to protect some surrounding structure of the ventricle. Okay, this next case is septum pellucidum cyst case. So this is a preoperative septum pellucidum cyst. She shows a cognitive function disorder. So we use this videoscope to this big cyst. So we can catch the cyst very easily by this endoscope and coagulate and cut and fenestrate by ballooning technique. But you watch the internal cerebral vein under the cyst in this case. This is a post-operative view. Cognitive function recovered very well. This is a intraventricular abscess case. DWI showed mainly left lateral ventricular abscess. So I usually use wash out the abscess using a videoscope because the inflammatory reaction goes quickly down after the irrigation. So piloasis was used and videoscope was inserted. You can see many debris in the left ventricle. So I wash these debris by artificial CSF many times and attach the debris should be removed by forceps or something like that, piece by piece, gently. And vision getting very clear. So this case is a shunt removal and replacement case. Congenital hydrocephalus boy, and from the posterior horn, shunt tube was inserted into the lateral ventricle, but you can see a very tangling choroid plexus, and the whole hole was stacked. So I inserted this videoscope from the anterior horn and watch and cut and coagulate the choroid plexus. So if you don't see and blindly withdraw, maybe bleeding, massive bleeding occur. So cut, withdraw from the posterior horn, and insert, replace the correct position, not to tangling the choroid plexus. It's convenient. This is a shunt replacement case also, trapped fourth ventricle case with hydrocephalus of the lateral ventricle. This is a preoperative MRI. I'm planning this one tube will be inserted into the lateral ventricle to the trapped fourth ventricle. So this is a videoscope view. The third ventricle floor. We can't see any connection between third ventricle and the fourth. So fenestration will be made using the navigation system, sometimes use rigid scope. So combination work. This is a rigid scope, and assisted to that was a This is a fourth ventricle. So inserted along with the neuroendoscope. I inserted this catheter. So this is a post-op. So think about rigid or flexible. I'm not sure. I have no idea, no answer this question, especially in Japan. Rigid scope is very, 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 very clear, and use very narrow space, and navigation can be assisted. So flexible videoscope is clear, acceptable, I think, and simultaneous manipulation can be done, and easy to focus, autofocus, and wide view. That is the advantage of videoscope. So in my conclusion, although rigid scope is developing, for example, 4K, 8K, flexible high-resolution videoscope may play a role in some ventricular manipulation, especially in Japan. I'm not sure in this country convenient or not. Thank you very much.
Спасибо вам, доктор Оно. Есть вопросы? Если нет вопросов, перейдем к следующей лекции. Следующую лекцию будет читать доктор Шигео Ямаширо по теме возможности 3D-экзоскопа сосудистой нейрохирургии.
Second, I'll talk about the experience of exoscope. Dr. Kurozumi talked about this one AM session about my experience. So the introduction of an operative microscope was the most important revolution in modern microneurosurgery as a result of the more bright lightning and magnification. Recently, the advent of the exoscope has enlarged this perspective, and in addition, its compact size makes the visual direction free, and this is a kind of screen, so-called screen surgery, like any endoscope surgery or abdominal or urological surgery. Maybe a next generation microneurosurgery. We have experienced the use of 3D Bitom system generated by the Karl Stoltz and tried to do for 3 patients operation. 2 patients is aneurysm creeping and the other case is carotid endarterectomy. And this is the first case, the 71 female showing the unruptured aneurysm arising from the bifurcation of middle cellular artery. The height of the aneurysm is 4.5 millimeter. The operation, you can see the so bright and than the microscope, I think. So now incising the dura mater and exposing the frontotemporal brain parenchyma, the frontal and temporal, and inside the arachnoid membrane, and going into the sylvian fissures, we can see the many arachnoid trabeculars visible. So cut the arachnoid and going into the deep and deep. Maybe operative view is bigger than and effective than the microscope. I feel the zoom function is so good. So the aneurysm is exposing here. And this is aneurysm, very yellowish and so atherosclerotic. The neck is, the bilateral neck is here, so ready for the clipping. The operator clipped the aneurysm by the left hand. And in this case, the operator achieved the neck clipping under the exoscope only, not use the microscope. So, but Bitom system does not include the ICG videography, so the operator changes to the microscope to use the ICG videography. So the microscope view is so clear and higher resolution at the benign, high magnification than exoscopes. I feel color is natural. The ICG videography showing the aneurysm is no visible aneurysm and other associated arteries clearly visible. The patient had a good postoperative pulse. Second case is also unruptured aneurysm arising from the anterior communicating artery. The aneurysm shows a small but the irregular shape, which has two domes, aneurysm is located slightly high from the skull base, so I choose the anterior interhemispheric approach to achieve the round aneurysm. The exoscope make a magnified view from the start of skin incision. This lateral frontal bone was exposed and the craniotomy was made. The dura was exposed. I choose the left dura inside and going into the interhemispheric fissure. This breaching vein is so interrupted. So very narrow space in the interhemispheric here. I am going into the fissure. The arachnodal trabecula is cutting. And this is the anterior skull base here. And this is the olfactory nerve and stretching by the down of the frontal lobe. I should prevent this disorder of the olfactory nerve function. So the tuberculum zere is visible here. So it's so deep here. So the operator is me. I decided to change the microscope because of the resolution is so not so good of the exoscope. And this is a microscopic view. The left frontal lobe, and this is the anterior communicating artery. A1 is here, and A2, and aneurysm is here. So this is also yellowish and atherosclerotic. The ACOM and ACOM attach the aneurysms. So I detach this attachment from the micro scissors, and neck space is conformed bilaterally. So I choose the bayonet type creep. The creep is applying the neck. So the blade, length of the blade is enough, so the preparation is over. The post-operative course is no problem. The third case is showing the 77-year-old male right carotid stenosis. This MRI shows the right carotid narrowing of the carotid I see, this is a post-operative MRI showing it enlarged. And my exoscope view of the carotid endarterectomy. The operator is not me, he is a specialist of CEA. The skin incision was made under exoscope. The platysma is cutting. And sternocleidomastoid mastoid muscle is exposing here. And retracted to the operator. So the fat tissue is here. Dissecting the fat tissue bluntly. We can see the common carotid artery here. This fat part is cutting and peel out. Oh, excuse me. So the fat is peeled out and the carotid system is exposing. And this is the hypoglossal nerve, external carotid artery, and common carotid artery. And this is the ansa cervicalis. The internal carotid artery is exposing by cutting the ansa cervicalis. So superficial thyroid artery is tenting. The EC also tent. IC is clearly exposing. So at this time, operator decide to change the microscope because it's not used to be. This is a microscopic view. The arterial incision is marked. The IC to the common carotid. This is a confirmation of the not blood flow, and inside the artery, not bleeding. So inside to the internal carotid artery, and the yellowish plaque is exposing here. Atherosclerotic plaque was removed, peel off and remove gently. This is a normal internal membrane. and totally removed. The arterial suture was made by the 6-0 size of the nylon. This is the last stage of a microscopic image. The clip was removed and the blood flow is recanalized. And this is the ICG videography. I confirmed the flow of the blood. So the complete hemostasis, the wound was closed. Okay. I think about the advantage of endoscope are this one, more magnification potential, effective digital zoom, free visual direction, so because of the compact size. Operation feel more comfortable because of the free visual direction. But I think the disadvantage here, not good visual quality in deep and higher magnification. The assistant, for assistant, they have put out the hand with different angle from the screen monitor viewing, but maybe it's used to be. And this system did not include not foot switch and ICG videography, but it is improving. This program is improving near future. The conclusion: 3D exoscope showed comparable features in visual field, stereotactic impression, and magnification, with a clear benefit concerning the ergonomic possibilities from microscope, but the limitation of the exoscope appears a little rough resolution in deep and high magnification field. Okay, thank you very much.
Спасибо, доктор Ямашира. Будут вопросы? Если нет вопросов, спасибо. Следующую лекцию прочитает доктор Тадаши Ватанаби. Кейхол доступ при доброкачественных опухолях головного мозга.
Okay, good evening, everybody. I'm Dr. Tadashi Watanabe from Nagoya. Okay, it's coming. Yeah, it's coming. From Aichi Medical University. I used to be in Nagoya Red Cross Hospital. Actually, since until last month I was there, but I have just moved to Aichi Medical University now. And today's my topics is about the endoscopic keyhole approach for benign tumor like meningioma and okay. Why? I think he was effective. Yes, sorry for waiting, and yes. Okay, this is the paper from this year, JNS, from New York, Professor Theodore Schwartz. They reviewed. Oh, okay. Yeah. They reviewed endoscopic scalpel surgery. And in this introduction, Professor Charles Wilson said, he said a strong message for us. I read this. The precondition that is often forgotten in the excitement that comes with change is certainly that the new technology will improve the quality of clinical care for patients. If this condition is not satisfied, the technology should be abandoned. So it means, so we have to remember this thing every time. We, like us, who trying to do a challenging every day, we have to remember this message. Okay, and in this review, he said, he mentioned about a clear advantage for a transnasal approach for craniopharyngiomas and choromas. The extended endonasal approach have a clear advantage for these two pathologies, and additionally, the most of the meningioma, including the trabeculum sella, they have an advantage. So the endonasal approach is almost matured in now. So, okay, so, and now we have the new weapon called the exoscope, like Dr. Yamashiro and Dr. Krosmi said. And I also like this. I am one of the most heavy user of exoscope in Japan. And the advantage of this exoscope is it is small. Because it is small, the handling is really easy. And also the accessibility to the surgical field is easy because it is small, the head is small. And visual accesses are totally free, and so the posture of surgeon is easy. Imagine you operate the infratentorial approach, your arm is always up, but no, using exoscope it is easy. And also the patient position is also easy. So we always do the vestibular schwannoma in supine position with the exoscope. Okay, so, and I show you this approach is our three mainstream of endoscopic neurosurgery for brain tumors. The one is the endonasal approach, and the second one is the cylinder approach. Maybe Dr. Takeuchi will mention about cylinder approach after this presentation. And today I talk about keyhole approach. This one. Keyhole means with a small craniotomy, we do a surgery for extra axial tumors. And this is the number of my personal experience. So these two are a relatively small number, but I'm trying to do better surgery every day. Okay. And, okay, so this is the characteristic of endoscope. First of all, it has a wide viewing angle, and second one is through a small hole, you can go into the skull. And so it means a minimum invasive approach. And another one is endoscope can be 2 or 3. I call this the multi-view surgery. I talk about this later. And also, we can observe the objective underwater. That is only available, only in endoscope, not a microscope. So, And wide viewing angle means radicality of the surgery. And at the same time, the less invasiveness means the possibility of a palliative therapy, for, especially for old elderly patients. And I also show you later. Okay. And these are tips for endoscopic keyhole approach. And actually, I use exoscope initially, and change to the endoscope after finishing some craniotomy and approach. And I always do a surgery with two endoscopic surgeons. Endoscope is held by a pneumatic holder, which is controlled by the assistant. The guide of endoscopy by the assistant is really important for this approach. So always we do this surgery with two neuroendoscopic surgeons. And generally, 2.5 to 3 centimeter is appropriate size for this approach. Less than this size is uncomfortable for a surgeon, but if it is bigger than this, like a 4 or 5 centimeter, it is the endoscopic is unstable. I always put the endoscope at the edge of a craniotomy, so this size is the best size, I believe. Okay, so this is superior keyhole approach. So I always make a skin incision along the superior edge of the eyebrow, and preserving the supraorbital nerve, we cut the periosteum, the curved incision, and we drill the inner table here. Yes, inner table of the craniotomy, and do the surgery. I showed one example. This is the clinoidal meningioma. After using an exoscope, we drilled one bone, and now I'm dissecting the tumor from the brain, from the arachnoid, and now I'm detaching. So this is the endoscopic view already. And you can see the optic nerve here. The attachment is lateral to optic nerve. And here's some adhesion between the arachnoid and the tumor. And using this wide viewing angle, you can see the inside here. This is oculomotor nerve. Then this is the oculomotor triangle. You can see clearly inside the oculomotor triangle. And now you can see the posterior clinoid. So when the endoscopic is reaching to the objective, you can see the enlarged view. And now I'm looking up to the middle skull base, just beyond the sphenoid ridge. So always it is difficult to observe there by microscope, but it is easy to observe. And now I'm removing a tumor around the optic canal. So now I'm looking from inside, medial. So here's the optic nerve, and I'm removing the tumor from the optic canal. Actually, we didn't drill the optic canal, but we have just cut the fasting home ligament here, only this. No bony drilling at all. And we could achieve the total removal in this case. Okay, and this is another example for multiple pulsing meningioma for the case of NF2. And you know, the interhemispheric fissure around the falx is, it's a kind of a secret garden for a neurosurgeon, because there is no bridging vein between suprasagittal sinus and inferior sagittal sinus, so we can go through anterior to or posterior, and we can remove the tumor as you like. This is post-op. And this is a case of recurrent epidermal cyst. The patient underwent multiple surgery, and there's a recurrence. And the remnant tumor is around the midbrain and also around the medulla. So we did an endoscopic anteropetrosal approach for this case. So not only around the pontine, prepontine cistern, we can observe the upper area or lower area using an angled scope. So now I'm removing the tumor, I'm dissecting the tumor capsule from the midbrain now, maybe using a 30-degree angled scope. And now this may be the fifth nerve, and this is the space created by drilling of the Cause's triangle, and you can see the posterior fossa area through this approach using angled scope. Okay. So how about this intra and suprasellar lesion, which is extending laterally? So in such a kind of case, we use a multi-scope surgery. This is a picture of Picasso, and the eyes and the nose are drawn at the same time from a different point of view, which is the feature of the Picasso work. And also, I think Marc Chagall, who was born in Russia, he also used this method, I think. And we adopted this technique to the neurosurgery. We planned fully endoscopic combined transsphenoidal and supraorbital keyhole approach for this kind of tumors. For example, this is the craniopharyngioma. So tumor is arising from the stalk, but tumor is extending laterally. And maybe there's the perforators from the PCOM is around here. So we chose this combined approach. This is a view from exoscope at the craniotomy, and this view is from eyebrow approach, and this one is from below, the endonasal approach. So now I am dissecting the tiny vessels attaching to the tumor, and also the upper team, they also are detaching the tumor from the structures. And we can cooperate together in this case, like this. Because of running out of time, I skip. So you see this is the tools from above, and this is tool from the nose. And okay, so there's a four instrument here. So this is PCOM and perforators. So I think this is a real forehand surgery from a two direction. Okay, this is the advantage of combined surgery. Okay, so this is the other way to use the two endoscopes for a pontine cystic tumor. Here's a nodule. So to remove the nodule, we approach from here using a subtemporal approach, and we put the sheath into the pons and then remove the nodule. And so during the removing the nodule, we observe the surface of the pons to keep the safety. And this is another way to use a two endoscope. Endoscope and exoscope. So this is a case of MVD. we sometimes experience the observation at the ventral side is difficult, especially in the case of a facial spasm. And I tried this kind of simultaneous, multi-scope technique using exoscope and endoscope. So it is really safe to do the surgery, but actually the setup of this surgery is a little bit complicated so far, but maybe I hope the new system will come. So I am waiting. Okay, so, and this is the meningioma case at the posterior fossa. This old man is 85 years old, and during the follow-up at the outpatient clinic, they developed a floating sensation and a right clumsy hand. So what to do? 85 years old. And he doesn't like to be operated. But there is a symptom, so I suggested him just internal decompression through a small hole, without exposing the brain or without exposing a CSF, like this. The craniotomy is like this, the 3 centimeter, and open the dura at the tumor, and just do a decompression and coagulation of feeding arteries. And I said to the junior colleague who did this surgery, never expose the brain or never expose CSF. And finally, he completed the surgery. And this is just next day, just after the CT. This old man felt no headache, no nausea, no vertigo at all. And he's eating food. And this is the post-operative one, day 1 CT. You can find no air is inside the skull. This is only in the tumor cavity. And this is the 1 week post-operative MRI. There remains a tumor here, but it doesn't matter. And 2 months after the surgery, like this, it is shrinking now. And maybe you can find there's no difference between post-operative day 1 and 2 months. There's no air and no difference here. So, and I'll show you another palliative surgery for an old lady who developed the bitemporal hemianopsia with the tuberculous meningioma. And she didn't like to be operated, and I suggested her, I will never touch any brain or any optic nerve, any structures, but I will just remove the bone and coagulate the attachment. That's all. Maybe you will be fine, believe me, I said to her, and she accepted. And I did just a drilling of the planum or tuberculum cellae and coagulated the feeder from the, from a posterior ethmoid artery or the capsular artery. And this is 1 week post-op. There's not so much difference, but actually the symptom gradually improved after 1 month. And this is the 1 year post-operative MRI showing a little bit getting down. And you can see a little bit bigger space in the third ventricle, and the tumor is moving like this to ventral. So, and she is really fine, and the symptom is improved until now. Okay, this is another case. This is also the 82 years old female, unplugged meningioma. She developed disorientation, the dementia, with a strong shift and edema. What to do? she's 82 years old. So I suggested her to just decompression. And because there may be the vessels between tumor and the brain, so we preserve everything, every vascular structure along the brain. Using an exoscope and endoscope, actually we did. So exoscope can move easily, so axis of a viewing angle can be changed easily, so it was really effective. And this is the post-operative MRI. Of course, the tumors remain around somewhere here, but this is 1 month after the surgery. The shift is recovered, and she's really fine. And actually, the disorientation improved. So now she is really clear, and she came back to the normal life. Okay, so at the end of the presentation, I talk about a little bit about the tools, and we have to choose the special tools for endoscope like this, the monoshaft one, or a small forceps, or rotating dissectors, or malleable suction. And actually, we developed a malleable dissector like this. This is made in Japan, which has 2 bendable points. I designed this kind of wavy design because we can bend any direction. So, and it is easy to bend it back, reshape. Okay, and this is malleable but tough, not too soft. Malleable but tough, it is an important point. And we have a variation of a tip shape, and this ring dissector has the shape of the transection is a triangle, so it is easy to make the the surgical plane between tumor and normal tissue, especially for this kind of adenoma. And we also developed a really fine dissector, forceps dissector. This is the case of cervicum meningioma. There's a SHA is going into the tumor, but it might be passing through. So I am dissecting this tiny vessel from the tumor using this fine forceps dissector. Sometimes we experience this kind of situation. So using this forceps, finally we could dissect a small vessel from the tumor. Okay, this may be the last slide. Okay, so this is my conclusion. In treatment of benign tumors, the role of endoscopy is important both in the radicality obtained by the wide field of view and in palliative treatment in aging society. Thank you very much.
Спасибо, доктор Ватанабе, за интересную лекцию. Будут вопросы?
Thank you, Dr. Watanabe. That was a fantastic talk, terrific talk. 2 questions. One is about this inside subtotal coring of the big meningioma, the posterior fossa meningioma.
Yeah.
Is there a concern about possible hematoma formation in the tumor cavity?
No, I think in case of meningioma, once you control the feeding attachment and the feeding arteries, I think there's not so much risk. It's not a adenoma.
But the meningioma, the posterior fossa meningioma, where you just went into the tumor without disturbing the brain or letting out the CSF, that was purely an intratumoral operation? Intratumoral operation, no CSF or brain was exposed? So how do you get to the feeders through that approach? You cannot, you go to the side of the tumor to detach the blood supply?
In this case, there's much bleeding from the petrous bone, and we control the feeders. And finally, we could control the bleeding. So I think this is enough for this surgery.
Okay. One more. Just about that old lady with the tuberculum cell and meningioma where you just coagulated the blood supply.
Yes.
Yeah. You think radiation, it is greatly reduced the tumor size, which is really nice. Any point in giving radiation to that patient?
Radiation?
After the operation, maybe?
No, I think the optic nerve is already weak by compression, so we better avoid radiation. In such a case, we don't do radiation. Yeah.
Если больше нет вопросов, с последней лекцией выступит доктор Казухита Такеучи на тему эндоскопический порт для интракраниальной патологии.
Good evening, everybody. I think you are very tired, but this is last talk, so please enjoy. Okay. My talk is about endoscopic surgery for the intraparenchymal tumors. I usually use I usually use a cylinder for intraparenchymal tumors. This surgery comes from the hematoma evacuation surgery invented by Dr. Nishihara in 2000. And recently this approach is used for the intraparenchymal tumors. Dr. Kasan reported in 2009. There are many cysts. Translucent cylindrical shaped cyst is inserted to the region to keep the surgical corridor and protect the surrounding brain. We use this type of cylinder, 10 millimeter cyst and 6 millimeter cyst. This one is not available in Japan. And I dislike the taper shape. This one is available, but I don't use it. This is how to introduce the cylinder. Okay. Endoscope tip is calibrated by navigation system like that, and so we can notice the location of the endoscope tip. And endoscope inserted into the translucent cylinder, this one, and insert the endoscope to the translucent cylinder. And for doing so, we can notice the location of the endoscope tip, and we can see we can get the direct viewing of the surgical site like that. Okay. The next is surgical maneuver inside the cyst. The assistant holds the cylinder, and 2.7 was 4 millimeter diameter endoscope is inserted inside the cylinder, and 1 or 2 thin instruments are also inserted coaxially like that. And sometimes drip line is also inserted inside the cylinder to fill the inside the cylinder with water. We call this technique as a wet fill technique. I'll show you later. Removal technique inside the cyst is divided into two, one-hand surgery and two-hand surgery. In one-hand surgery, the endoscope and suction monopolar are mainly used. And the cyst is held by assistant, and the main surgeon holds the endoscope and other instruments. It is possible to change the direction and the operation field dynamically by tilting the cyst like this. This technique is useful for the hematoma removal surgery, and also useful for the suckable tumors. But disadvantage of this technique is a hemorrhagic tumor and hard tumor. In two-hand surgery, endoscope, suction, bipolar coagulator, and forceps, everything can be used. The sheath is held by assistant as a one-hand surgery, and the endoscope is held by the endoscope holder. Surgeon uses suction and forceps. It is easy to achieve precise dissection and hemostasis. Tumor developing is also possible by using scissors. This one is good for the hard tumor and eloquent area tumors and hemorrhagic tumor. But this technique needs larger diameter sheath. If you use a larger diameter sheath, like a view-side disc-shaped cylinder, surgical maneuverability improves, but the surgical corridor becomes large. So it depends on the case. This is a surgical tools. At this surgery, we use the 6 mm diameter sheath and 2.7 mm endoscope was inserted, and we performed the two-hand surgery. But in this surgery, we have to use a very thin forceps and marble forceps or very thin bipolar or something like that. And we use this type of endoscope holder, Olympus end arm. I think, unfortunately, this end arm is not available in this country. And the movement is like this. We use forceps open and close movement to dissect the tumor from the surrounding brain. This movement is quite useful. I show you some cases. This 42-year-old female appeared with a headache, and MRI revealed carcinoma, 4.5 centimeter carcinoma, like that. We use 2.5 craniotomy. And at this surgery, we use 10 millimeter sheath. Inside the cylinder, inside the tumor, like that. At first, the solid compartment was appeared, so we performed the two-hand technique to remove the tumor, like that. After that, we fill it with water, so-called wet field technique. Under the water, we dissect the tumor from the surrounding brain, like that, and cut it, and remove it. This is a post-operative MRI. All tumors gone. And this is the surgical corridor, very minimal. And the skin incision is here. I think it's small enough. And we also use a 6 millimeter diameter sheath for this kind of relatively small tumors. This 27-year-old female appeared with a headache due to the hydrocephalus. We made a 2 centimeter craniotomy and inserted a 6 millimeter cylinder, like that. At first, we coagulate the choroid plexus a little bit because she had a relatively large choroid plexus. And then we dissect the anterior septal vein here and coagulate it and cut it to enlarge the foramen magnum. We got a larger approaching route to this region here. tumor has a calcified component here, so we break and remove the tumor. After the internal decompression, we can dissect the tumor from the surrounding brain like that and suck up the tumor. And this is the final view. All tumor is gone. And damage to the foramen magnum is minimal, I think. I think the 6 mm diameter is small enough to insert the foramen magnum. And post-operative MRI should not go to the removal in this surgery. This is a recurrent GBM case. He already received the craniotomy and chemotherapy, including bevacizumab. So the patient received the bevacizumab treatment, so the larger craniotomy is not suitable for this patient because of the wound problem. So we choose, we choose the eyebrow skin incision and insert the cylinder from this side. At first, we perform the eyebrow skin incision and craniotomy and insert the cylinder with navigation guide, this one. Fortunately, the tumor is really soft, like that. It's a suckable, so with one hand technique for this case, suck up the tumor. But there are many arteries here. So we coagulate these arteries with a two-hand technique. Of course, this is GBM, so there are many arteries, but we can coagulate the arteries like that. At the bottom of the tumor, there are many feeding arteries, so bleeding is started, but we can control it with a two-hand technique like this. Okay, this is MCA. I think we removed this area. And I think good removal was achieved, like that. And nowadays we use direct cortical stimulation for this kind of surgery. He received twice craniotomies and radiotherapy and chemotherapy, so the skin is quite weak. So we cannot perform the big craniotomy for this patient, so we chose keyhole surgery for this patient. But the tumor is very close to the pyramidal tract, and the patient does not have any symptoms at this point. So we use the direct cortical stimulation in the endoscopic surgery. We dissect the dura from the brain and insert the strip electrode. And fortunately, again, the tumor is suckable, so we can suck up the tumor with a bimanual technique, like that. We remove the tumor with a subpiral fashion, like that. And after the removal, we use NIM monitoring to confirm the pyramidal tract. And at this point, we can get some response. So we stop the removal. But still, I think it's a very good removal. As the other doctor said, we can use the 4K endoscope nowadays. So we can detect small arteries like this. But to detect the tumor is very difficult, even using the 4K endoscope, because how do you identify the tumor from the normal brain? I think you can see the tumor. The color is not normal. Color is a little bit different, and the tumor is soft, and the suction sound is a little bit different from the normal brain. But in the cylinder surgery, the response of the forceps or some other instrument is not so direct, and sound is not enough here. So to resolve this problem, I use 5-area fluorescence. This patient had a relatively large GBM case. We made a 2-centimeter craniotomy and insert a cylinder from this side and this side. After the removal of tumor, we use 5-area fluorescence. This is the tumor. This material can be attached to the endoscope very easily, and we can change the light with a foot switch. It's really useful. And gross total removal is achieved like that. And nowadays I use ICG for the tumor. Do you know the second window ICG? ICG can be used also in the tumor surgeries. I made a 2-centimeter craniotomy, and this is a 5-area fluorescence. You can see the tumor here, but it looks like the tumor is here. But this one it looks normal, but it contains the tumor. And this is the ICG. ICG response is achieved get from the enhancing mass. After the removal of the main part, we confirm the no 5-area response like that, and complete removal was achieved like that. This is my personal experience of the cylinder surgery from 2013 to last year. I experienced 91 patients, and the gross total removal was achieved in 64%. That is depend on the pathology. So the removal rate is not so problem, but like that. And the complication rate is here. No mortality, and morbidity was seen in 4.6%, but almost the complication was transient. 2 transient ataxia in 2 cases, and transient ptosis was seen in 1 case. And unfortunately, I have 1 permanent complication, abducent nerve palsy, in 1 case. The summary is here. Endoscopic minimally invasive approach for interparenchymal tumor with transparent cyst is safe and effective. I think the development of the surgical instrument will expand the indication of this surgery. In wet field studies, the surgical cavity is kept inflated naturally and the brain shift is less, so the navigation is always used. It is always correct. And 5-area fluorescence and direct MP are also useful in the endoscopic surgery. Thank you very much. Any questions? Sorry? Photodynamic therapy. I don't use it because there's no good machine to connect to the endoscope. Yeah, I know. But in Japan, the PDT is only performed in some institutions. But in my institution, we don't have such instrument, and maybe some permission is required to perform the PDT in Japan, but we don't have it, so we cannot do it.
Thank you very much for good talk. And I have one question. In GBM case, sometimes we have to remove the GBM into the ventricle. So, and you sometimes use a wet field operation.
No, I don't use wet field technique for the malignant tumors. At the final stage, I use wet field technique, but in the first stage or in the middle, I don't use it.
Yeah, I understand. Yeah, I'm afraid dissemination.
Yeah, I know.
Спасибо, доктор Такеучи. Это была последняя лекция на сегодняшний день. Сейчас будет вручение сертификатов, а после вручения сертификата будет трансляция из операционной фенестрация кисты силевой щели. Спасибо.
Тоже большая. Так как мы используем этот шунтоскоп в этой операции, поэтому по ходу пьесы все увидите, что такое шунтоскоп. Он и в первой операции использовался, показательно нашей. И сейчас будем использовать. Вот. И там по ходу пьесы будут вопросы, будет сделать. Поэтому сейчас мы все формальные процедуры проведем, вручим сертификат, а потом уже дальше каждый остается, смотрит, сколько сможет. Хорошо? Договорились? Вот в таком ракурсе. Не буду писать. Ну что, понравился всем курс? Лектора серьезные такие. Подъехали, молодцы. Самое главное, беззаветно делятся, вот, без всяких секретов. Я смотрю, все показывают, открывают. Это очень дорого стоит. Вот. На самом деле, хочется, конечно, сказать спасибо большое профессору Йоко Като. Переводите кто-то, нет? Переводите, да? Да, на самом деле, конечно, хочется сказать спасибо большое профессору Йоко Като, потому что вот этот семинар эндоскопический, который у нас ведет, это полностью ее инициатива. И она постоянно это поддерживает везде, присылает людей, собирает вот таких лекторов. Представляете, насколько это сложно и трудно, на самом деле, вот таких вот профессионалов вот, собрать и сюда привести. Вот поэтому хотелось бы, чтобы такие очень... Thank you very much for Professor Kato, okay, because for his pushing and supporting this endoscopic seminar here in Тюмени. То есть вы все должны это понимать, говорю, это полностью под эгидой инициатива профессора Йоко Като. Вот именно этот эндоскопический курс идет. Так, ну начнем сертификаты вручать, самая приятная часть. Сертификат вручает Исам Балу. Поздравляем.
Thank you very much. Feel so pleased and so privileged to attend this scholarly meeting, have reached some experience of mine. And I'm welcoming all my colleagues and, of course, the faculties and the scholars coming around the globe. I'm feeling very lucky to be here in this rich institution under the leadership and the scholarly of His Excellency Prof. Albert Akramovich. Thank you for leading this institution to be in the rank of international recognition. Thank you.
Thank you, sir. Дмитрий Хаскелевич. Салават Мирхайдаров. Поздравляем, Салават.
I want to say thank you to all participants, faculties for coming here and tuning in the middle of the summer, in the middle of nowhere almost. And I want to say thank you, my professor, Albert Akramovich Sufianov, and all of you and all staff of this center, because we are a big family, big neurosurgical family.
Thank you, Salawat. Good luck. For Salawat, I see every course is more fluently speak English. It's very well. Бахадир Бабаханов. О, наши друзья с Ташкента, да? Спасибо большое. Сертификат. Фото на память. Что-нибудь за слово скажешь?
Моя фамилия Бабаханов, зовут Бахадыр. Я работаю в Центре нейрохирургии из Узбекистана, город Ташкент. Хотелось бы поблагодарить наших лекторов за очень хорошие, просто великолепные лекции с демонстрацией клинического материала. Хочу пожелать вам крепкого здоровья, плодотворной работы на благо наших больных. Спасибо огромное.
Спасибо большое. Удачи. Улугбек Асадулаев. Спасибо большое. Это наши старые реально друзья. Мы уже знаем 1000 лет друг друга, да? Кстати, знакомство в Японии, по-моему, тоже произошло.
Да.
Да, я помню.
Ну, дорогие коллеги, дорогие профессоры из Японии, Альберт Акрамович, это было действительно очень познавательно и для нас. Ну, желаю всем спокойствия и в работе удачи. Очень было красиво. И приглашаем в Узбекистан. Будем ждать тоже.
Спасибо большое. Спасибо. Удачи. Александр Теплорухов. Андрей Лещинский. Это тоже один из наших российских лидеров. Слава Богу, что ездит, не забывает нас. Спасибо большое.
Спасибо большое, Альберт Акрамович. Спасибо за предоставленную возможность участвовать в таком прекрасном курсе. Спасибо нашим прекрасным лекторам за такой прекрасный материал. Действительно, знания, которые мы здесь получаем, являются для нас, ну, наверное, первоочередными. Мы должны получать знания от наших, ну, как бы лидеров нейрохирургии. И от этого мы получаем возможность потом применять их на деле и помогать нашим пациентам. Спасибо вам огромное.
Андрей Кузьмин. Поздравляю.
Меня зовут Андрей Кузьмин, я из города Челябинск. Это город на Южном Урале, 500 километров от Тюмени на юго-запад. Я бы хотел сказать еще раз спасибо. Я здесь не первый раз. Очень польза была или нет? Да, была польза. Я на самом деле, у меня отсутствует опыт в эндоскопической хирургии. Мы хотим освоить ее в нашем городе, и поэтому Я заведующий, да. И ну, по эндоскопии я отсутствие опыта полное, поэтому для меня это очень полезный курс, и буду надеяться и буду предпринимать.
Удачи. Удачи, спасибо. Игорь Батурин.
Игорь Батурин, я также из Челябинска, третья областная больница, работаю с Андреем Николаевичем. Уважаемые лектора, огромное спасибо за то, что поделились с нами своими знаниями и умениями. Постараемся это все применить на практике, применять, учиться у вас. Альберт Акрамович, огромное спасибо за то, что в очередной раз нас собрали на очень толковый обучающий курс, как всегда. Спасибо вам и вашему коллективу.
Удачи, удачи.
Все.
Фарид Тагдиров, Баку, да? Тоже наш старый товарищ. Не забывает, спасибо.
Я Фарид Тагдиров из Азербайджана, Баку. Это недалеко от Каспийского моря, с Кавказа. Я здесь неоднократно бываю и с каждым разом все больше и больше влюбляюсь в этот центр и здесь всех сотрудников во главе с Альбертом Акрамовичем. И каждым, так скажем, приездом сюда все хочется больше и больше сюда возвращаться. И не только набираемся тут опыта, и практического опыта в нейрохирургии, но также получать энергетику, такую же положительную энергию от Альберта Акрамовича. Всем спасибо большое. И кроме того, мы обычно привыкли как-то больше с Европой, больше ездить в европейские какие-то конгрессы, но я очень рад, что Тюмень превращается одним из центров, так скажем, мировой нейрохирургии уже, где объединяется Азия и Европа, можно сказать. Спасибо большое.
Спасибо большое. Бахрус Айвазов. Бахрус, спасибо.
Меня зовут Бахрус, я тоже из Баку, из Азербайджана. Я первый раз в Тюмени. Спасибо за приглашение, спасибо за информативный курс, спасибо профессору, который из Японии. Было очень информативно и полезно. Я думаю, что в следующем году я буду чаще приходить здесь. Спасибо. Все.
Гамзат Алиев. Гамзат. Замучись, Расула.
Алиев Гамзат, город Санкт-Петербург, Институт мозга человека. В Тюмени я впервые был наслышан о центре от своих коллег, и от Салавата тоже постоянно слышал. В действительности удивительная работа проводится. Те 2 дня, которые мы провели здесь, они были очень эффективными, очень познавательными и какую-то мотивацию дополнительную дали. Рад знакомству с вашим центром и с вами, Альберт Акрамович. Спасибо большое, что даете такую возможность развиваться.
Спасибо, спасибо, удачи. Лев Чекалин. Республика Татарстан, да, Казань. Поздравляю, Лев.
Я из города Казани, зовут меня Лев, фамилия Чекалин. Огромное спасибо Альберту Акрамовичу и уважаемым профессорам, лекторам нашим за те знания, которые мы в этот раз получили. Я думаю, что данный цикл, он не только в важен тем, что вот мы получаем эти знания, хотя это первостепенно. Но во-вторых, мы знакомимся друг с другом, мы познаем опыт других стран, также делимся мнениями, с кем-то спорим, в хорошем смысле этого слова, завязываем какие-то контакты. То есть этот цикл, мне кажется, что он и для всех, для нас в дальнейшем даст какой-то толчок в развитии и дальнейшем общении друг с другом. Спасибо большое.
Удачи. Мануэль Рамирес. Доминикана. Да? Congratulations.
Thank you so much. My name is Manuel. I'm from Dominican Republic. This is my 8th or 9th time I'm here in Tumen. Thank you so much to Professor Sufiano for all his team, from the good job they do here with the patient and with the residents to come here to take all the knowledge is here. Thank you so much.
Thank you, Manuel. Thank you. Good luck. Сейчас, конечно, поблагодарить хочу свою команду, своих сотрудников, которые организовали и подготовили такой прекрасный цикл. Вот, на самом деле, конечно, это очень, вы все заметили, командная работа. Все приложили усилия. Большое всем спасибо. Ну и поименность, это Александр Ковалев. Все, наверное, запомнили, здесь первый курс диссекции, да? Первый курс диссекции. Все запомнили? Как Саша преподавал. Спасибо, Саша, большое.
Спасибо всем большое, кто...
В нашем центре. То есть человек пришел год назад, да? Ну и понятия не имел ни от колбы хирургии, вообще нет. Сейчас это один из лидеров. Год работы.
Спасибо. Спасибо всем большое, кто имел отношение к этому курсу. Спасибо участникам, спасибо лекторам. Это было полезно, особенно для таких молодых специалистов, как я. С некоторыми из вас мы обменялись мнениями. Может быть, для вас это тоже было полезно, я надеюсь. Вот. Обычно после таких мероприятий я вспоминаю одну из моих любимых фраз. Чем больше я знаю, тем больше я понимаю, что я ничего не знаю. И это дает повод идти дальше. Всем спасибо.
Спасибо. Удачи. Гаджимурат Гаджиев. Спасибо, Гаджимурат.
В первую очередь хотел поблагодарить организаторов такого семинара, профессора Суфянова и особенность наших лекторов и профессора Ката. И наших лекторов, которые проделали нелегкий путь, чтобы добраться до Тюмени. Спасибо.
Thank you. Рахманджон Рустамов.
Спасибо большое. Я Рустамов Рахманджон Равшанович, аспирант кафедры нейрохирургии. Да, на самом деле в этом году наша конференция прошла очень интенсивно и очень так полезно. В этом году многие лектора из Японии, участники ближнего и дальнего зарубежа, из нашего соседней республики Узбекистан. Вот, всем спасибо.
Спасибо. Артур Печерица.
Hello, everybody. My name is Artur. I am a resident this center. I am very happy to be here, and I want to say thank you very much to Professor Sufyanov, Albert Karamovich, for this seminar, and I would like to say thank you very much our guests for your lessons, for your knowledge, because it's It's a really priceless experience for me. And I hope we will meet again. Thank you so much.
Good luck. Сейчас мы приступим к такой торжественной части. Еще раз от всей души хочется поблагодарить не только вас, участников, но и лекторов. Просто очень сложно вырываться. Я просто по себе знаю, чем дальше в лес, тем просто очень сложно. Поэтому низкий поклон за то, что вы все приехали, делитесь своими знаниями. И еще раз низкий поклон профессору Йоко Като, который собрал такую просто невообразимую блестящую команду здесь, в Тюмени. Ючи Нагата.
Thank you very much for your kindness of all staff in this institution, and I wish our relationship will last long time. Thank you. Спасибо.
Thank you. Thank you. Такуихира Хиде. Thank you. Thank you.
Thank you very much for Sriyanov and faculties, and I very appreciate for the hospitality. Yeah, and I get many friends here, so I'm very happy. Спасибо.
Thank you. Thank you. Good luck. Казухика Куразуми. Thank you.
Спасибо большое. So thank you very much, Dr. Skanov and everybody, for giving me a chance to talk and giving a data. And I had a good time to be here. And if you have a chance, please come to Okayama in Japan. Yeah, we're welcome. We have 4K or 8K and Japanese cartoon or anime, you know. Thank you very much.
Thank you. Masao Tambara.
Thank you for Professor Sufyanov and our staff and faculties and participants. It's very long flight and come here, but I have very big experience. Thank you very much.
Thank you. Good luck. Shigeki Ono. Thank you.
Thank you very much for your very heartwarming hospitality, and I never forget this tremendous experience. Thank you so much.
Thank you very much. Shigeo Yamashiro. Thank you.
Thank you very much, Professor Sufyanov and other colleagues and faculty. And this seminar is very impressive and informative, also for me. So, thank you very much.
Thank you. Good luck. Tadashi Watanabe. Thank you.
Thank you very much, Professor Sufyanov, and every faculty and participant. And I really enjoyed this experience, including 2 surgeries. It was really exciting for me. And I like this city, really pleasant and really good people. And I really like this, and including food also. So I would like to come back again, and I will meet again in some day. Yeah. Thank you so much.
Thank you. Good luck. Ramesh Nair. Very old friend. Ramesh. Thank you.
First, I must congratulate Professor Sufiano and his team, his assistants, his residents and trainees and students and the organizing staff. They did a wonderful job, I have to say. I think the whole conference was a total package. You have the best lectures, best teaching, excellent surgeries by the team here. And what else can I say? The hospitality, the social program, and the food, and also the vodka. It's fantastic. Love to come here again.
Thank you. Thank you very much. Okay. Also, my old friend and honorable guest of our courses, Professor Tariq Salahuddin, Pakistan. Thank you very much for coming.
Thank you very much. I always get very excited whenever I'm traveling and teaching, but I'm so impressed by the young neurosurgeons from Russia, Serbia, and especially Tumen. You have really impressed us. Your enthusiasm for knowledge, you are already quite knowledgeable, but the way you have responded, I salute your enthusiasm. It can never be a one-man show, and I think Professor Sofianov has shown his leadership, and he leads from the front. He is a very old friend. He's been coming to Pakistan and exhibiting his surgical skills, and he's a very popular person there. But when we come in here and we see your institution, it is an extraordinary organization that we have seen. The faculty which has come from Japan, from UK, and myself, I would like to thank them because they're very busy people. But I think they have taken time to come all the way to come and teach. Not only to teach you, but it is the service towards neurosurgery. And I think it's a long way to go. And I see, Professor, not only neurosurgery, but the way I look at him is one day probably he becomes something very big at the Kremlin in Moscow. But I wish you all very much. Congratulations to the team who has done a very hard work to organize this beautiful conference. And I'm sure I would like to thank Professor Yoko Kato, who I'm sure will come one day, and I will accompany her with my Japanese friend because she's a great teacher. And especially I would also like to thank all the ladies, Anna and I think Alia and the lady there, and everybody who supported this conference for their hospitality. The cuisines were excellent, and we really enjoyed our stay in Tumen. I thank you all on behalf of my faculty and myself very much. I thank you very much.
Thank you very much. Thank you. Thank you. And my co-director, Kazuhida Dakiuchi. Thank you.
Thank you very much, Professor Spianov. I really enjoyed. I'm very impressed by your hospitality again. And I hope this meeting is meaningful for you all attended. And please practice endoscope to keep that knowledge, and please keep our friendship. Thank you very much.
Thank you. Окей. Значит, сейчас, я думаю, маленький перерыв. Сейчас начнется живая хирургия, киста седой щели. Вот, ну, теперь в свободном режиме. Кто может, кто хочет, остается, досматривает. Понятно, да? Дальше уже по ходу пьесы посмотрите сами. То есть маленький кофе-брейк. Окей?
Отлично. Пациент 11 лет, фундаментальная киста средней проемки слева. Вот, выполняется сейчас доступ. Планируется эндоскопическая пенетрация цистерны узнавания черепа.
Что? Хорошо, представьте, покажу. This case.
Структура доступа через микроскоп. Как будет сам эндоскоп от точки входа до цели. Это вот сейчас в микроскопе сейчас видно. Это показывает желтого цвета, куда мы входим. Средней черепной рамки подавать второго типа. Симптоматически. Видно, есть гипокарпия, видно сонная артерия. Сам эндоскоп будет проходить
This case.
к межжелудочковую сцену, и нам нужно делать перфорацию. Обычно делается в треугольнике между владельным нервом и сонной артерией. Сейчас потом выберем лучшее место, может быть, это может уже.
Есть какие вопросы?
Скажите, изображение есть у вас?
На эндоскопе появилось изображение? Насечник появился.
проводим навигацию эндоскопом. Самой навигации. Если они пределы допустимого, то мы соглашаемся. Акцепт. Вот здесь вот такая траектория будет для фенестрации кисти. Это мы видим по сканам с аксиальным, с фектальным. Вот. Можно также сделать эндоскоп. Теперь немножко увеличить кончик. Траектория, как пройдет эндоскоп, где он как раз мы по траектории считали всевозможную цистерну, трахеазма, есть желтым цветом выделено мамиллярные тела, аксиальные проекции хорошо видны ножки мозга. Значит, вот в эту проекцию гиппокамп светится синим цветом. В принципе, автоматическая регистрация позволяет нам полностью эти структуры визуализировать, знать, где они находятся. Сонные артерии красным цветом. Все необходимые все структуры можно визуализировать. А вот здесь настройка эндоскопа сейчас идет, его ориентация вверх-вниз, резкости, настройка. Вот видим стенку